for you guys, then they might be making faces at me. I won't even know. I have pretty good peripheral vision. So. All right. Well, it's about almost time, right? Yep. 2:45. Okay, well, I'll get a couple minutes.
Oh, I was like, we can get started, and I'll introduce you.
Okay, great.
All right, guys. So we'll get started with our last breakout session for the day. So I have the pleasure of introducing Dr. Jodi Smith. She's an academic pediatric neurosurgeon at Riley Hospital here, right across the street. And she's the assistant professor of neurological surgery in the Department of Neurological Surgery at IU School of Medicine. She received her PhD in anatomy at the University of Utah School of Medicine for her doctoral dissertation studies on neurulation. Dr. Smith subsequently completed medical school and residency training in neurological surgery at the University of Utah as well. Following residency, Dr. Smith completed a pediatric neurosurgery fellowship at Children's Hospital, Harvard Medical School in Boston. Dr. Smith joined the Department of Neurological Surgery at the IU Medical Center back in 2000. And we are very happy that she is here with us today.
Thank you, Rachel. I actually, I really love kind of doing this because I really love what I do, and I think I have a pretty cool job. And I think that when I give talks like these, I think about what it was like when I was where you're sitting, and you know how exciting it was to think about what I was going to do for the rest of my life. For me, it was maybe a little bit different because I kind of had my plan all, what it was. So I'll just, first of all, I titled my talk, Humanism in Pediatric Neurosurgery, How Important Is It? And I would say to you just right off the bat that it is extremely important, no matter what you do, whether you're a surgeon or whether you're a pediatrician or whether you're just any type of physician. Humanism is the most important. It will keep you, and I hate to say this, but it will keep you out of lawsuits and things like that. What I think it means to have humanism in pediatric neurosurgery is just to love your patients, to love your patients' families, to be a part of their family, to be available to them. And that's not easy. It's not easy at all because they will call you at all hours. So when I'm driving down here from the North Office, so I saw patients up there, I'm driving down, one of my patients' moms texted me and she said, could you please call Doreen Whitney? She's with the Make-A-Wish Foundation, and Tanner might get to go on Make-A-Wish if you call her. So, I mean, it's just like, all kinds of crazy things happen during the day, and that's easy to try and get a wish granted for a child. Go ahead and change slides. So I think when I was kind of thinking about this talk, it's taking your scientific knowledge and your skill set and combining it with respectful, compassionate care that is sensitive to the values, autonomy, and cultural backgrounds of patients and their families. So and how do you do that? And I was so I've been very blessed. I think that's kind of one of my gifts, and I thank God for that. But I have a good rapport with all of my patients. My families trust me. And one day, Dr. Schreiner, I don't know if you know him, he was basically the chief pediatrician at the hospital at Riley for many years. And he came up to me, I was like coming out of McDonald's with my fish fillet and my Coke and my fries. I did that every day when McDonald's was there. I was really sad when McDonald's left. But anyway, so Dr. Schreiner came up to me and said, how do we teach the medical students and the residents to be like you? And I'm like, what are you talking about? And he said, well, all of your patients and their families, they love you. And I'm not trying to brag or anything, but because all of them, I mean, they're so, like at that time there was like the Caring Bridge, and there were, now it's Facebook, and you get all these comments on Facebook about if you're a bad doctor, they comment about you. If you're a good doctor, they comment about you. And so, and so he asked me, I said, I really don't know. But I think that it kind of comes from within. And I think it's this humanism in medicine. I think it's very, very important. Next slide. So let's go ahead and just, so I want to show you a Holden story. This is just a little that I took care of a number of years ago. Whoops, there we go. And then go ahead and, yeah.
And I'm 8 years old.
When Holden was 2, we noticed that he started complaining with back pain.
That was really not fun.
So we took him to the doctor. They had some testing done. They did some x-rays and said he was constipated. I knew something was wrong as a mom. It just had gone on too long and there was no relief for him. So we called Riley to have an MRI done.
My back really hurt because I had a tube inside my spine.
I'll never forget that day. We only had a couple options, if we did nothing, he would be paralyzed within 6 months' time, or we would do the surgery. I mean, it was just terrifying.
And Dr. Jodi went and got it out.
When Dr. Jodi came out, she said that woman had done great, and it went better than she could have hoped for. All the doctors were great there. Physical therapists, neurosurgeon, you name it, everyone there was phenomenal. I can't thank Riley enough for what they did for Holden. They gave us our family and basically his life.
Dr. Jodi Raw.
I don't feel bad, actually. It kind of gets you ready to go, right? So, you know, I think that they did this commercial with this little boy, but it really kind of captures how the families feel and how, you know, and how these patients feel. And I think you need to remember, and I know you're taught all throughout medical school and residency that they're not just so-and-so in room 34, or, you know, 104 or whatever. These are real live patients. And if you're going into pediatrics or pediatric neurosurgery, you also have to deal with the families. And that sometimes can be very hard because every mom and dad, and if any of your mom and dads in here, you can relate to this, but every mom and dad thinks that their child is the only child on the planet, and their child is the most special thing. And you have to believe that as well, no matter how many kids you're taking care of and how difficult, you know, the difficulties that they're going through. You have to really, you know, take care of them as if they're a part of your family, or as if they're, you know, very, very important to you, and they are. And I think that that's part of the humanism in medicine. All right, next slide. So before, you know, so how did I kind of arrive at where I am right now and who I am? So this is me in the 5th grade, and then in high school, I was always involved in sports. I love sports. I was very competitive. You can see that I had a lot of first place ribbons. I let the 2nd place one be up here, but like the 3rd place is clear down here because I wasn't very, very happy with that. And then I got one friend over there, Susie Burnham, who has a 2nd place ribbon. So I was very competitive, and I played all the sports, did pretty well in high school and I was going to be a coach and PE teacher. That's what I wanted to do. That was my goal. Until I went in and talked to, and I actually got a softball scholarship to play softball, and I went in to talk with one of my high school teachers. His name was Joe Roberts. He was the men's track coach and my physiology teacher. And I went in and I talked to him and I said, Mr. Roberts, can you give me a letter of recommendation? I need one for college. I got a scholarship. I just need to get in now. And he said, well, what are you going to do? And I said, I'm going to be like you. I want to be a teacher. I want to coach. And probably going to teach PE. And he said, no, I'm not going to give you a letter. And I said, what do you mean? I'm the best student in your class. I'm the valedictorian of this high school, and you should give me a letter because I deserve it. And he said, well, why don't you think about doing something else? And I said, what? And he said, well, why don't you become a doctor? I'm like, so if I go pre-med, you'll give me a letter? And I said, okay, I'll go pre-med. So I really didn't know what I wanted. I mean, I kind of had that in mind. I really didn't know what I wanted to do. And I'm not a millennial. I'm kind of like in the baby boomer, era. So I didn't have parents that were really pushing. My parents would have been happy if I would have been, and then as long as I was happy, they wouldn't have cared if I collected garbage or what. I mean, I'm serious. They really didn't see what a future for me. They wanted me to be happy. And so next slide. So I went to Weber State, which is about a 25,000 student college in Ogden, Utah, just north of Salt Lake City, and played on a 4-year softball scholarship. And while I was at school, I did go pre-med. I was interested in going, I was med bound. And, but then I met Gloria Wurst, and she was like a major kind of stepping stone or mentor in my life. And she was amazing. She could do anything. She's a zoology professor. She taught anatomy. I took cell physiology from her, and she asked me to be one of her teaching assistants. And then I got interested in doing a research project with her. And I fell in love with research. We actually looked at early development of the pineal gland and the pituitary gland. And I thought, wow, this is really cool. And so I actually applied to go to graduate school at the University of Utah. And so next slide. So I thought this is what I would do. I'd go to graduate school. I'd kind of look at the research and see if I liked it. If I didn't like it, then I could always apply to medical school the following year. And so I got but then when I went into interview, they said, now you're not going to just go to medical school next year, are you? You're going to, if we give you this, if we spend money on you, give you a stipend to do research, you're going to complete our program, right? And then I thought about it, and I thought, yeah, I'm not a quitter. I'm not a quitter at all. That's not me. So I think if I tell you I'm going to do this, I definitely will go the road. So what I did in graduate school was I looked at early neurulation, and neurulation is the stage of development, which I think is one of the most important stages because that's where the nervous system forms. So brain and spinal cord development occur during neurulation. I looked at cell shape changes during bending of the chick neural plate, and this is a scanning electron micrograph of a chick embryo going through the stages of neurulation. I thought that was just so fascinating. And I thought, well, we need to understand how it works normally, how the process works normally so that we can understand abnormal development. I started to think about abnormal development and babies with spina bifida. And I was doing research in the lab one day. I was getting ready to defend my dissertation. I had a couple more things I needed to do. I was doing an operation on chick embryos. So a stage 4 chick embryo is tiny, tiny. You have to do it in the microscope. And I had a little cactus needle mounted on a little stick with nail polish, and I was taking out this little piece of the chick embryo. Actually, I was doing it on a quail embryo, and it was a Hensen's node, and I transplanted it into a chick embryo because you can tell the difference between the cells if you stain it a certain way. I wanted to know what happened with those cells. And one of the fellows, pediatric neurosurgery fellows at Primary Children's, walked in, and his name was Mark Diaz, and he looked at me and saw what I was doing. He said, wow, if you could do that on a chick embryo, you could be a pediatric neurosurgeon. So I said, tell me about pediatric neurosurgery. I'm fascinated about, I really think that's pretty cool because I thought that, looking at early development of the brain and spinal cord would go well with a job in pediatric neurosurgery. And so I had him tell me about it, and I kind of fell in love with the idea. Next slide. So then I had a real big decision to make because I was just getting ready to defend my dissertation. I had a postdoctoral fellowship lined up, maybe 1 year, and then I graduate and I go out and I do research, teach medical school, anatomy probably because that was the emphasis of my degree. Or I decided to go to medical school for 4 years, neurosurgery residency for 6 years, fellowship for a year. And so, so I do what I always do when I'm faced with a decision. And a lot of people write the pros and cons down. For me, I say a prayer and I'm like, what should I do? And ask God, what should I do? And it kept coming back that I needed to be a pediatric neurosurgeon. And that's a big deal. I mean, because I'd already been in school, right? So I'd already done my 4 years of undergraduate, 5 years, took me a total of 5 years to complete my PhD. And then I'm faced with another several years of down the road if I choose it. But I felt that was really something that I needed to do. And so I took the MCAT. I only applied to 3 medical schools, and the University of Utah was one of them because I thought if I stay at the University of Utah, I can continue to do research, and that will be really good to get into a neurosurgery program. And so I was blessed to be able to stay at the University of Utah, and I did graduate first in my medical school class. There weren't very many women in my medical school class, but I was the first to graduate in any medical school class for women at the University of Utah. That was in 1993, and then I got accepted into the University of Utah program. And the cool thing was that I got to work with the guy on the top there, Dr. Jack Walker, Marion Jack Walker. He was a pediatric neurosurgeon that was just a very kind, very humanistic pediatric neurosurgeon, and I spent as much time as I could with Dr. Walker as a resident, and it was just an amazing experience. And then I applied for a pediatric neurosurgery fellowship and got into Boston Children's Hospital, which was another blessing and an answer to prayer. And then I got to work with my very favorite pediatric neurosurgeon, Mike Scott, who is still just an amazing guy. And while I was there, it was just like a magical year. I did 463 cases, and I was there at the hospital all the time. I was working in my patella. I don't know what Boston looks like because I was in the hospital so much. But one time he came up to me and he had a case. He said, "Can I run this case by you?" I'm like, "Sure, Dr. Scott." I'm the fellow, so yeah, sure, Dr. Scott. And he had this scan, this MRI scan on actual film, and this boy had a brainstem tumor. And it was a very difficult tumor for Dr. Scott to operate on because the kid had a kind of a large head and it was difficult to reach the tumor. And he'd been in this kid's head before and couldn't get to the tumor. And he showed it to me, he said, "What would you do with this?" And I said, it just came to me. I know it was an answer to prayer. It just came to me and said, "Why don't we use the Nd:YAG laser?" And he goes, "What's the Nd:YAG laser?" And I'm like, and I had used it with Dr. Walker. I used it for different surgeries with Dr. Walker. And it's like a laser with a little fiber tip that is on a long handle that you can get into deep places, and you can use it to take out brain tumors. And I thought that would be the perfect thing. I told them, I said, we should do it. And they didn't even have an Nd:YAG laser at Boston Children's Hospital, #1 children's hospital, many, many years running. They didn't even know what that was. So we got them to bring it in. We did the operation, and Dr. Scott asked me if he could take it out. I said, yeah, you can do the honors. You can take it out. And he got it out. And come to find out, we didn't really know this, but the child that we operated on, the family was just really, really wealthy. And so they donated a laser to the hospital in this fellowship name. And then they've given Dr. Scott's program like up to, I think it's almost now like $5 million in the name of like the Pediatric Neurosurgery Fellowship and whatnot. So Dr. Scott always goes around and says that I got him his professorship and all of that. But I learned so much from him. And he's the kind of guy that would go to the operating room and address everybody. And as he would walk out, he would thank everybody. And it didn't matter who it was in the room. He just knew everybody by name. Okay, new slide. So, and then after I graduated from my fellowship, I was fortunate enough to join Riley Children's Hospital. It was a great, I'd never been to the Midwest. I had no ties to the Midwest. When I interviewed here, I felt like it was where I needed to be. And the chairman of the program at that time, Paul Nelson, and you're going into, I was going to his office to interview, and I knew him just a little bit from before, because I actually interviewed here for fellowship at a couple of other places. And when I came back to interview for a job, I went to shake his hand, and he goes, "Oh, come here." He gave me a big bear hug, and I'm like, I like this guy. He reminded me of my grandpa, right? So I just felt really like this was where I needed to be, and it has, and I've been at Riley now for about 18 and a half years, and it has been an amazing time. Next slide. So blessed to be at Riley. This is the new Simon Family Tower. You have everything you need to practice, to do all the kinds of complicated neurosurgical procedures that we do. And I'm blessed to work with nurses and ICU staff and anesthesiologists, and even the people who clean the instruments down in the SPD in the basement of the hospital. I mean, we are so blessed to have all of these things, and that has really helped me to become successful in my career. Next slide. You can see in the operating rooms, it's pretty complex, and you're not even seeing half the stuff that's in there. This was the first operation that was done in the new ORs, and that was my patient. It was a Moya patient, so I got to be the first one to do surgery and to basically christen it with the Moya case, which is a really cool operation and a really cool disease process that I'm glad we have an operation for. And it was Dr. Scott that came up with it, developed the operation that we use at PLC angiosis, which is really cool. And so I was blessed to be able to train with him and bring that to Indiana. Next slide. So every day I operate. Every day I come to work. I take care of kids with life and death situations. I mean, I could be called to the ER like right now, and there could be a child dying in the ER from a brain injury or a brain tumor that's bleeding, and so you kind of, so it's a high stress, very challenging job that you don't know how high stress and challenging it is until you're like in the shoes of a pediatric neurosurgeon. But it is most amazing. It's the most amazing feeling to be able to operate on a child and get them through a really difficult operation. So I do brain and spinal cord tumors, neurotrauma, so head injuries, spinal cord injuries, neurovascular disorders, ruptured AVMs, arterial malformations, Moya syndrome, hydrocephalus. That's very common. It's where the ventricles in the brain dilate out because there's a block in the system. And then a whole bunch of different congenital brain and spinal cord abnormalities. And it's just unbelievable. And just when you think you've seen everything or done it all, something else comes in and just like, whoa, this is incredible. So next slide. So so I have the opportunity that I get to lecture here at IU, and I also get to lecture at Marion, which is pretty fun. But I remember one of my last lectures, maybe it was a couple of years ago, maybe it was this year, I can't remember, but no, it's not. It was probably 2018. But we had enough time at the end, which is rare because I usually take too much time talking. But we had enough time at the end that I was able to ask for questions. And I thought this was a really insightful question. And the student asked me, he said, how do you handle those oh my gosh moments? And I thought, wow, that is a really, that's a great question. And I mean, just kind of getting goosebumps when I think about it right now, even because those oh my gosh moments are the things that make you or break you, really. And you have to be prepared for them. And I thought about it for a couple seconds, but I didn't have to think about it very long. And basically, for me, and I've had some crazy oh my gosh moments lately. And you know, sometimes you'll go for weeks and months and maybe even years without a real stressful, super stressful situation. But I always turn to God. Always, I'll pray, and I usually get an answer. And so with those difficult times in my life, especially in the operating room, or especially when, for example, I'm always on call. It seems like when the mass casualties come in, and I know I don't know what I'm going to be faced with. So the state fair stage collapse. I don't know if you guys ever remember that, but a number of years ago that went down, and so I was on call. I drove in and got in, and I ran to the ER because I knew something was going to be for me. Ran into the ER, and all of a sudden a nurse in the ER comes running out. She goes, I need mannitol stat. And I'm like, mannitol means brain injury. So I said, where are we going? To CT scan. So this kid almost died in the CT scan. I took her out. But anyway, she made a really good recovery. But you just never know what you're going to run into. But I remember going there that night, and coming in that night and just saying a prayer in the car, asking God to help me, direct me to where I needed to be, and direct me to do what I need to do to be able to take care of anybody. And I thought, and even if I can't take care of any kids, because there's nobody at Riley that got hurt, then I'll just run over to Methodist, I'll run over to Eskenazi, I'll do whatever I got to do to take care of those kids. So, it always seems to the answers always seem to be there when I did that. So the other thing that I did that day when I were talking about the oh my gosh moments, I talked about a case that I had, and this is a little boy that the only patient that I've ever had die on the operating table, and that happened when I was when I started at Riley in July 2000, and this little boy died in December 2000 on the operating table, and he had a brain tumor. He actually, go ahead, we'll just go through it. We'll go through it pretty fast. So he's 15 months old, beautiful little baby, blonde hair, blue eyes, just the cutest kid you've ever seen. He'd been sick for about 6 weeks. He'd had irritability. Of course, brain tumors aren't common, so they get diagnosed with things like sinus disease or otitis media. So he had laryngotomy tubes placed. But then he was still crazy irritable, and they were giving him hydrocodone for pain. They were giving him narcotics for pain. He was so irritable. But then he became lethargic, so I finally took him to an outside hospital. And unfortunately, they did a lumbar puncture. You don't want to do a lumbar puncture in a kid who has a big brain tumor because you can herniate and kill him at that point. But luckily, he didn't die. They saw increased protein, and then they got a head CT scan. And then they transferred him to Riley, new slide. He weighed about almost 10 kilograms, so about 22 pounds. His vital signs were his heart rate was really elevated because he was crying. He was extremely irritable. Very inconsolable. He had an open bulging anterior front. Now, at 15 months old, it should be closing, not closed, but it should be wide open and bulging. He had mild right-sided weakness, and the remainder of exam was unremarkable. Next slide. So here's what he had. So he had this massive brain tumor. I mean, you guys can all see it. This doesn't look normal. So, and as I looked at that, I'm worried about it being very malignant. He's a little 22, so 10 kilograms, so not a huge blood volume. Very vascular tumor, and fairly junior neurosurgeon, right? So, and on call. And he had a lot of shift, and this is just a bad situation. I would talk to the family. I told them that this is a bad tumor. I thought it was going to be a bad tumor, that if it were a highly malignant tumor, he may only live for 6 more months, even with radiation chemotherapy. New slide. So I started him on steroids and started him on IV fluids. I kept an NPO, so nothing to eat or drink. Admitted him, we got an MRI, brain, spine. There wasn't any drop metastases or anything like that in the spine. We admitted him and got him prepared for surgery. This was a Sunday evening. I was going to take him Monday morning. Unfortunately, around 2 in the morning, he started to become bradycardic. And bradycardia means herniation. And herniation means, Jodi, you better get your butt in there fast and get into the operating room and start operating. So that's what I did. I took him to the operating room, and I left temporal parietal craniotomy. So I took the bone off basically right here. And as soon as I took that bone off and opened up the dura, the brain just kind of swelled out. I mean, it was just coming out like crazy. And so I got in. So I had given him mannitol before, gave him some more mannitol. Mannitol helps with brain swelling, new slide. And then I got into the tumor. The frozen sections revealed that it was a small round blue cell tumor. And anytime you get that diagnosis, it's bad. It just means that it's a highly, highly malignant tumor. And I worked on it the entire day and came around it and got the tumor out, but I lost a lot of blood in doing it because it was just such a vascular tumor. I tried to work around it, but it didn't matter. Every time I even looked at it, it's like started to bleed. And that was a massive tumor, and you can't, it's really hard to take out a tumor, to move a tumor around like that. If you have to kind of get in, gut it out, bring it in a little bit more, gut it out a little bit more. But when you gut it out a very malignant tumor like that, you're dealing with a lot of bleeding. And that's a problem when you have a little boy that only weighs 10 kilograms and there's not a big blood volume. But anesthesia kept up. We estimated that he probably lost about 3 liters of blood. He got a lot of blood for his age and size. And at that time, we didn't have this thing called the massive transfusion protocol. So with massive transfusion protocols, when you're losing blood and you're giving blood, not only do you want to get packed red blood cells, but you want to get fresh frozen plasma, and you want to get platelets, and you want to keep track of the calcium and all of those things that are so important to keep, keep blood clotting and things like that. Because you lose, not only do you lose the blood, you lose a lot of the clotting factors. And so what you're doing is you're kind of creating a situation where you're going round and round and round. So you lose the blood, the clotting factors, the tumor bleeds more, you're losing more blood, more clotting factors. And so, eventually that's going to take its toll on the kid and potentially take the child's life. I'm focused on the tumor and trying to keep the bleeding down as much as I can. And anesthesia was doing a great job. And I got the tumor out, but I packed in I had packed off a lot of areas to kind of stop bleeding. And as I was taking out the cotton patties and things like that, he just started to bleed from everywhere. I mean, the IV started to bleed, the catheter started to bleed, the outline started to bleed, blood started coming out of the brain, and it was like, oh my gosh. He had gone into DIC, disseminated intravascular coagulopathy, and the anesthesia started doing chest compressions on the table, and I kept praying, but it wasn't meant to be, and he passed on the table. And we followed all protocols, and he eventually developed an agonal rhythm and died on the table. And just the final pathology was ATRT. That's probably one of the most malignant brain tumors that there is. And he probably wouldn't have survived much longer because even with chemotherapy, radiation therapy, we can't give radiation therapy to a 15-month-old or even chemotherapy. It's hard to keep these kids alive. But we estimated 3-liter blood loss, and his blood volume was about less than liters, so 780 milliliter blood volume. So I basically lost 3 whole blood volumes plus of his blood. Gave him multiple blood products, transfused to keep up, but he eventually died in boy, I'm a young pediatric neurosurgeon. I'm like, oh my gosh, what have I done? I'm like, I'm not losing it in the OR, but I'm just really, just like you would be. It's like, this is your child, and you just lost a beautiful little boy on the operating table. How am I going to talk to these parents? My partner came in, actually I'd called the partner in, Dr. Boas, he was helping with the case, and he came in, he goes, do you want me to go out and talk to the family? I said, no, I need to do that. I said, get out of here. I mean, I just, you're just like, what do I do? So I closed up, had kind of a while to think about what I was going to say to him, but it doesn't matter. Because you're going to say what you need to say when you get out there, but you need to tell them exactly what happened. I closed him up, made it look perfect, because if they wanted to view him, wanted to make sure he looked really good. So closed him, spent a lot of time on the closure, made it look perfect. And then I went out, and we had family support nurses at Riley, and they had family in a room, and there was a lot of family. There was like 20 people in the room. It was like crazy. I mean, when pediatric patients have brain tumors or Chiari malformations, everybody comes. Unless it's flu season, then they only make mom and dad come, but there was everybody there, they're all in the room. And I walked into the room, and mom and dad were over in the corner, and I just walked over to them, and I said, I am so sorry. And we embraced each other, the 3 of us, and it just seemed like we were hugging for like, oh my goodness, it seemed like a minute. And I kept saying, I'm so sorry, I had the tumor out. I went into the IC, and proceeded to tell them about that. And when we broke, and I was bawling, they were bawling, and I just kept saying, I'm so sorry, I don't know what happened. I mean, I knew kind of what happened, but it just, why did that happen? Because, why did that have to happen? And then when we kind of broke up the hug, the dad looked at me and then looked over my head, and his pastor was over here. And he said, "Come here, Pastor so-and-so." And he then asked his pastor to say a prayer for me so that I could go back out and operate on kids and do what I needed to do. I mean, this was close to Christmas time. It was just really, really, really hard. But I can tell you that day, that changed my life in a big way because, losing anybody is hard. And especially when you think of these kids as your own, family. But that dad, he could have been just angry and mad. And I don't even want to hear you, doctor. You can imagine all the things that could go through their minds. And they asked their pastor to pray for me. And I just thought that was amazing. Next slide. So about a week later, Mom sent me a 3-page letter and just explained so many things to me about how she was feeling. But this was the last page. So this is this little boy. I mean, you can imagine how darn cute he is. And she said to me that God was in total control of all that happened in Jeremiah's life. I'm so grateful for the way that you allowed God to use you to minister to Jeremiah and to us. You prayed for him. One of my friends told me that as she was praying on Monday, that was during the surgery, she saw angels surrounding the operating table. I believe there were. I believe that God guided your hands and allowed you to remove that entire tumor in part so that Jeff, the dad, and I would know that he, meaning God, was in total control. God bless you in the ministry that you have at Riley. God has placed you there, and I know that he will continue to use you in mighty ways to minister to many others. And in Christ love, Jeff and Kathy Stevens. And, it was just really, really touching that they would be able to, they knew what I needed. I mean, there's not a year go by that I don't think about this little kid, even especially at Christmas time. And I think that what I'm looking forward to, I guess, is, when I pass this earth and hopefully that I get a chance to see him and see, and see how he's doing, because I think that would be really cool. New slide. So let's look at Katie's story. So this is another girl that I've taken care of. It's really fun. Sorry, no.
Oh, is it
we
on?
actually close it down. So we have Katie's story there. So this is you can just, perfect. So
Before I had that MRI, it seemed like I was perfectly fine. I had spells of nausea and vomiting and headaches.
I knew something was very wrong.
I was only 7 years old when they told me I had a brain tumor.
The doctor told me to keep Katie in my sight at all times, not to let her sleep, and that getting her to Riley was an emergency. The ride to Riley was the worst car ride of our life.
When they tell you your daughter has a brain tumor, you feel helpless. You're in the haze. It's indescribable. They gave us a lot of hope at our first meeting at Riley.
Our first thought of Dr. Jodi Smith is that she was going to be our lifesaver.
She gave us the confidence because she was an expert. Everyone at Riley was incredible and truly caring about our daughter. The last thing Dr. Smith told us as she took my daughter away was, I want you to understand that I treat every child as if she's my own. That's how I'll make the decisions, and that's how I'll treat her.
I'm doing really good now. Sometimes I even forget that I had a brain tumor.
With Dr. Smith, you realize there are real angels on earth.
So they don't script these little commercials. The families get to say whatever they want to say. And, it's amazing, when you take care of these kids and you put your all into it and you're successful, that these families just, that they say these things and every time. Now she is actually a lot older now. She's graduated from college. And she's done some modeling. She's just very beautiful inside and out. And it's just, it's really neat to be able to have the opportunity to take care of these kids. And I don't have any kids. I have poodles, which are my babies, my fur babies. So every kid that I take care of, and I've got a big wall in my office. The pictures rotate every year. There are kids I've taken care of. I've done 4,500 surgeries since I've been at Riley, and I do. You know, I mean, some of them are a little bit less memorable than others, thank goodness, right? But it's a real, it's just an amazing feeling to have, you know, a patient that you've dealt with do really well. I'll run through this pretty quick. We've got about maybe 12 minutes here. Traumatic brain injury, big thing that we take care of. Now, if you're squeamish, don't look at this, okay? So this little boy, well, first of all, traumatic brain injuries is one of the leading causes of deaths and acquired disability in children and adults in developed countries, and we see it all the time. New slide, it's a big thing. But this is a little boy who was a number of years ago. He was in the car with his mom's boyfriend. Mom's boyfriend was driving drunk. He was in the front seat. He wasn't seatbelted, and he went through the windshield as they got into a car crash. Here's what he looked like at the outside hospital. Next slide. So I was on call that day. It was actually the Labor Day holiday, and the outside doc was like panicking. He said, I've never seen anything like this before. We need to get him to your hospital. I'm surprised they were actually able to even get him intubated. I mean, that brain injury went all the way down. This tissue that you're looking at here is almost all the way down to the pituitary gland, and you see that CSF and blood there. And so as I unwrapped him, I'm like, oh, wow. So got everybody involved, got my plastic surgeon involved, got the orthopedic surgeons because he also had a broken leg, got the eye doctors. That eye on that left side was totally out of that whole socket, and it was gone pretty much. Next slide. So I took him to the operating room and opened up, debrided the brain, closed the dura. We repaired the facial laceration. Had the oculoplastic surgeons come in and take out the left eye, and then close that, repair that, and then at the end of the day. So we started about 10 in the morning, and I was putting in the intracranial pressure monitor after midnight. So it was a very, very long day. Next slide. So here's what he looks, so here's what it looked like on the inside after I'd kind of repaired everything. Very, very deep. I mean, it was just, I mean, you could see what he looked like. It was, it's amazing he survived it, especially having to go to the little hospital in Podak, Indiana, and then coming to Riley. But we were able to do everything in kind of one fell swoop. Next slide. And so this is what he kind of looked like. Dr. Robert Havlick, one of our plastic surgeons, kind of helped me with the closure, and I think he did a fantastic job. And that's one of the neat things about working at a hospital like Riley. I have the opportunity to work with people that are just fantastic in terms of their abilities. And Dr. Havlick did an amazing job on this little boy. And you see the intracranial pressure monitor, the bolt there. Fortunately, his brain pressures never rose. I mean, he did amazingly well, and I was able to get that out in a few days. And next slide. And here's what he looks like after. So you take, so it's like, you might look at that little kid from the get-go and say, oh my gosh, he's gonna die. I mean, he looks horrible. He came in with a very low Glasgow Coma Scale score, so really very affected by the very injured, horrible head injury. But look at him. That's 6 months later in clinic, and I always like to think about this. Every time we lose a child, not only do we lose what they could have done what they could do for the world, but we also lose what their children could have done. So it makes it really kicks the stakes up, right? Makes the stakes a lot higher, because if you lose one child, you lose what their children could have done, their children's children, and so on and so forth. New slide. So this is my last patient I want to talk to you about, because this just happened fairly well, about 2 years ago, but more recent than the rest of the kids that I've shown you today. But this little boy, cute as can be, came in 9 years old. Tyler came in with a blue tennis shoe, blue high top, and a red high top on. He has a brain tumor. And I'm talking to the family, and I look down and I see these shoes are different colors. I'm like, what's up with that? And he goes, fire and ice. I'm like, okay. He said he loves basketball. He's a very good athlete. You can see him here, about as cute as can be. Actually, I think he was more like 9 in those pictures. But anyway, maybe he's 11. But very, very athletic and just on fire in terms of how good he is. New slide. So he had a seizure close to Christmas, or right after Christmas, And they took him to outside hospital. Head CT was read as normal. They transferred him to Riley. They did a 24-hour video EEG. That was pretty normal. He did not have to start on seizure medications, but he started to have bad headaches and started to have vomiting. Brain MRI was performed in an outside hospital, and that showed that he had this very small brain tumor. Next slide. It wasn't very big, very small, and you might, but it's in a really difficult location. And if you go through and you scroll through this, it's a very small tumor. And I thought, well, I'm not sure if that's what's causing your headaches. It's probably causing your seizures. We could watch this for a little while, first scan. And so the family decided that we'd wait for a few months to get another scan, and it had actually grown a little bit. So I gave them the option. And Tyler basically came in and said, when I go to the NBA, I don't want to have to worry about my brain tumor. And so I want you to take it out. And so I said, okay. So I don't know where this is going. Next slide. Okay. So basically, next slide. So what I found, so I did a whole workup and got him ready for surgery. We did the video EEG. Really didn't see any seizures. We did a functional MRI to see where he was, what hemisphere was dominant for language. Of course, that tumor's on the left side. So basically, right is this side and left is this side when you're looking at scan. So it was on the left side, posterior temporal, wrapped kind of around the brainstem, with a lot of blood vessels coming in from the posterior cerebral artery, and then left hemisphere dominant for language. So I had to plan a route to get to the tumor that wasn't going to interfere with his language. That was really important to me. And new slide. And so I took him to the operating room toward the end of May 2017, and got in there, little craniotomy opening, little corridor to the tumor. Everything was going really, really, really well. And the tumor was just about out. I saw these two blood vessels coming over the tumor, and I was afraid that they were going toward the brainstem. So I wanted to skeletonize those vessels, and then I said to my resident, famous last words, I said, I think I better take these before they get me. So we just kind of, I think I better take these vessels before they get me, because they were really big blood vessels. And so I went to cauterize the one, and all of a sudden the bipolar kind of popped. And then the next thing I know, and it hadn't moved, but sometimes because it's an irrigating bipolar, sometimes it does pop a little bit, because when the irrigation kind of hits the tip. And I have it on video, so I mean, it wasn't like I pushed it in the vessel or anything. I don't know what happened. The vessel just kind of went and started to bleed, and bled. I have never seen so much blood in my life as I saw that day in that little teeny tiny tumor. And what happened was the blood vessels kind of retracted under the tentorium, and they were very hard to see and hard to get, and I just couldn't even compress them. So to make a very long story short, which was about 7 hours of trying to get hemostasis, blood control, and he ended up getting 60 units of blood products. I called in a lifeline, I called in a partner. My resident was on call, and so he had to leave, and so I called in a senior partner, and during that and as I was trying to get hemostasis, he was holding a big sucker in there, sucking out the blood and trying to hold cotton patties on it so I could try to get control of the bleeding. And this was going on for hours, and anesthesia was doing an amazing job. They were using the massive transfusion protocol, so wasn't likely to go into DIC. I was getting tired because it was going on and on and on. And my partner kept saying, when are you going to quit? When are you going to quit? I said, this little boy is not going to die on the table. I mean, if he's not dying, I'm not going to quit. We're going to get him off the table. I guess he had been in situations before with attendings that he had worked with where they quit because they couldn't get the blood under control. So anyway, next slide. So he lost 6 liters of blood. So that's 3 more liters than the little baby lost. He had over 60 units of blood products. So 21 units of packed red blood cells, 12 units of fresh filtered plasma, 8 units of platelets, 24 units of cryoprecipitate and NovaSeta. I mean, that's a lot. That should have given him pulmonary edema or emergent pulmonary edema or something. I mean, he should have never survived. I walked out to the operator. So I eventually got him off the table. The brain swelled. I ended up taking out a lot of brain to get everything closed up. And when I walked out and I talked to the family after I got him off the table, it was about 7 hours. just blood control. So the whole operation was probably about 13, 14 hours. And I went out and I talked to the family and I said, well, I think that this is what happened. I've never had this happen to me before in terms of that situation. I've taken these tumors out many times before and that didn't happen. And I looked at him and I said, the only thing that kept your child alive during that surgery is he must have had a guardian angel in the operating room, because I prayed so hard during that surgery. I know my scrub nurse did too, because we've done a lot of surgeries together, and she's a rock. She's awesome. And the dad looks at the mom looks at dad, and she kind of slugs it. And she goes, "It's your father." I'm like, "What?" She goes, "I guess the grandfather had just died, and the little boy and the grandfather were extremely close." I'm thinking in my mind, "Cats, did he want him on that side, or was he going to keep him on this side?" I'm like, "Oh, you know." And and I told him, I said, "I don't even know what he's going to do. He might not even talk. He might not walk. The brainstem can be devastated. He lost so much blood. And when you lose a lot of blood like that, then you're dealing with stroke and all of those kinds of things." So I said, we're going to do what we can to get him better, but I have no idea what kind of child we're going to take off." Next slide. This was post-op scan, CT scan, all that white that's there, it's blood in the ventricular system. When I saw that, I had to put in an emergency drain, try and drain some of that blood out. So I dealt with that. Final pathology was a very benign tumor, a juvenile polycystic astrocytoma. So that was a good thing. Next slide. So 1 month to the day, and this is a video. So 1 month to the day. Oops, no, you don't have to do that. Just go back to the slide. So, and then just click on it. So 1 month to the day after the surgery, he was in rehab, and here he is. This is when you're taking care of little kids, you never give up. You just never give up. This is Tyler. And I couldn't even do that on a good day. Right? So, I mean, he's amazing. I mean, he just gets faster and faster. Okay, next slide. And then 2 months to the day. This is a video too. Okay, check that out. He's on his, now the coach is telling him to do different things with the ball. So now do it different times. And he's on this thing. And this is after he nearly died in the operating room. Windshield wipers. Pretty cool. Unbelievable. I can't watch. I mean, I love to watch this. I can't get enough of it. Honestly, okay. So the next slide. Well, we're going to end with this. So we had the opportunity not too long ago to have a kind of a reunion with the nurses that were in the operating room. So this is a video that you'll close down. So this is Tyler and my OR nurses, and maybe some of you, I don't know if we can get it from there, but I have it loaded up already. So end the show. Yeah, and then it's that one, and then let's click on that. Let's do that guy in there. Okay, there we go. Perfect.
You're dealing with somebody's life in your hands, and you know that if you let go, that they might not make it. Then the stress is huge. I mean, have you ever heard of the saying, you feel weak at the knees? I was sitting down and felt weak at the knees. I mean, it was a trying time. There's no question about it, but I was not going to give up.
I kept thinking about Jeremiah during that operation. I just couldn't.
December 2015, he had a seizure. He had a brain MRI scan done. And the brain MRI scan showed Tyler actually came in to me and I said, well, it's still pretty small. We can kind of wait and watch and see what happens with this. And he said, no, I don't want to have to worry about this when I go to the NBA. So I said, well, if you don't want to worry about it, let's go ahead and get this tumor out. I thought that it was going to be like any other day. Went in with a very small bony opening, a very small corridor down to the tumor to protect the brain, and then got under the operating microscope and started to take out the tumor. And it was going very, very well. The tumor was well behaved, but I knew based on the preoperative MRI that there were 2 large blood vessels that were kind of coming into the tumor. And when I decided that they were feeding the tumor, I went ahead and started to cauterize, and all of a sudden, whether they must have been super fragile vessels, but both of them started to bleed. They were both arteries, and they were both big, and they definitely started to bleed very, very rapidly. and I couldn't see them, I couldn't get to them. I'm nervous as we speak because that's something that I don't typically deal with. You can ask my nurses. The bleeding that I have during surgery is not anything like it was with Tyler. And at one point I was very concerned that the bleeding was bigger than I was, that it was out of control. And he ended up getting more blood products than probably about 100
I
of
should
my
have said
patients.
1,000.
I'm not kidding.
She just came back
I
and
don't know,
said that they started
I don't know, I
doing
said
it,
100, but.
and then she would give us updates about every 15 minutes. And she came back and kept giving us updates that we went through, 1 unit of blood, 2 units of blood. She got up to about 7, and she said, "I'm not going to tell you how many units of blood anymore." Everything goes through your head. You get to the point to where, you start thinking about, the comment was made, "We're not going to take him home." Things that went through my head was, you start thinking about donating organs, things like that. That was that far down to where you're basically, you're to the point to where you're at your bottom.
Finally, after about the 6th aneurysm clip and after giving a substance called Novo-7, which is a blood clotting factor, the bleeding stopped.
I think when you go through something like this, because you do go so far down.
To the nurses that were in the operating room that night that changed their
A lot
lives.
of times, you don't, I think a lot of patients don't get that opportunity. So when you get that opportunity, there's that connection.
But 1 month to the date later, Dad sent me a video of Tyler, and immediately when I got that video, I got down on my knees and I thank God, because I know that it was more him than me for sure. And it was meant to be that he be here right now telling his story. What do you think? I feel okay? You're my most challenging case in this whole life of mine. I've been a neurosurgeon for 18 years, and that definitely was the most challenging case, but you know what? It was
So that was in the Indy Star at the end of I think it was in October, and I was really glad that he got to tell the story. But I would just say we'll end it right here because I know you guys have to finish up this conference. I really do think that this is a great conference for you guys to kind of learn about the more important stuff about what you'll do. And I would say to you that just always remember how you would feel on the other side if it were you in those parent shoes, or if it were you in your patient shoes, and try to treat them with as much respect and as much love. Don't put your clinics, make your clinics so busy that you don't have time. A lot of times these patients will come from 100, 200 miles away, 3 or 4 hours away to see you in clinic, and you're going to spend 5 minutes with them. Don't do that to your patients. Let your patients, treat them like you need to treat them. That's the hardest thing for me right now is it just seems like we're so focused on going away from patient care, and it's all about administration. It's all about numbers for U.S. News and World Report. It's all about metrics. No, it's got to be about the patient. It's about the patient. They deserve to have your undivided attention, your thinking about them and doing what you can to get into the literature to provide evidence-based care. But sometimes it's just that humanism, side of me that what they need. They need you to know, or they need to know that you care about them, that you're doing everything that you can for them, and that that's what it's all about. That's at the end of the day, it still makes me just can't believe that. I'm so happy that he is alive, and I don't know what I would have done if he'd have died. I'm not breathing. It's just really hard, but hopefully I would have been able to get through it, but I don't have to worry about it because he didn't. He's going to be something when he grows up. So I appreciate you guys listening to me. It's kind of like you get to toot your own horn, but I hope that through these experiences and patient case illustrations, you can kind of see, how important it is to just be there for your patients, give it your all. Every patient deserves 150%. Try to be as positive as you can, even when the outlook might not be. But you always want to be honest. You never want to sugarcoat anything. You want to get have the parents help you make decisions. Have your patients help you make decisions. Don't go over their heads and not include them. So that's my kind of 2 cents worth. So thanks for listening. Probably out of time.
3:37.
What time did I have to go to? 3:30?
What time?
Okay. Anybody have any questions if you want to come up, but otherwise, it was 3:30, right?
Yes.
Okay, so.
Okay. Thanks for covering.
Yeah.
Probably parking pass.
You're recording, yeah.
But if I possibly get your, okay, that would be amazing. Okay.
So let's do Jason.
Okay, cool. Thank you so much. I will send you the
Dr. Smith, I want to have to know it's like, oh, this is for you. Thank you so much for coming. Oh, it's always a good time.
You're so
I love you. I love you.
Hi, I'm Cindy. I'm the first year American student. And I appreciate amazing your passionate for pediatrics.
Yeah.
I actually want to be a pediatrician as well, but I'm not sure.
You know, I think that kids are amazing. And like I said, I was at clinic just before here, and I did like an operation on a little girl. She's probably red hair. And she's wearing this shirt that says, I'm a big deal. I'm some kind of a big deal. And I'm like, that's a great shirt. And I think they had a shirt for me like that in the bag. So I'm like, put it on.
Yeah, you guys can match. Yeah.
It's just like your own.
Uh-huh. I think it is important that you can visualize, give them the space.
Especially kids, because they remember it forever.
Oh, yeah. And I would love to get your contact information, if that's okay with you.
Yeah. You're more than welcome to come and see. I want to see. Yes, I would
Love to, thank you. You knew I was getting at.
Yeah. There's some people in the audience that benefit. So it's just Jason at
Hey.
Yeah, that's
Perfect.
it. Yeah,
Thank
yeah.
you so
And
much.
usually what I do is if you guys want to come in or shadow or whatever, I'll send you to my secretary by way of email and they'll should be
Okay.
And then, and I'll be up at St. Bees a little bit too, so for the marrying students, that might be kind of a way to go as well.
Mm-hmm. Perfect. Thank you for your time.
Always good to see you. Yeah. Nice
Track
face.
has to go right.
Yeah.
I aspire to be something like that in the future. But as an undergrad, I did an apprenticeship with a postdoc student, and we did check embryos.
Did you?
So like my
Where
here I'm at IUPOI with Dr. Balecki Adams. But they were kind of like studying the neurology and developing check embryo, and postdocs all had their own projects, but I got the job allocating antibodies and whatnot, but eventually near the end of my apprenticeship, I was able to like eggs and actually do stuff.
Yeah. With the dental drill. And
I would love to shadow and see what kind of experience and what your day-to-day would be like.
Sure.
And
Sure. So you got the two.
yes,
You
you said J. Smith at goodmancampbell.com.
Okay. Good.
I look forward to it. Thank you so much.
I'm Cassie Anderson. I'm an undergraduate at IUPOI. I'd love to tell you sometime. I've got your
email. Yeah. So email
I'm
and
just wondering, with your research background, do you still do any sort of
So
research?
I would love to get back into the neurulation research, but the problem is that is a very time and labor intensive, and so the clinical, very busy pediatric clinic or pediatric neurosurgery clinically. So I haven't been able to get into that, but I do actually have. So one of my other specialties I didn't talk about today is epilepsy and epilepsy surgery, and so we actually I have a lab that's called the Laboratory Discovery of Anti-Epileptic Drugs. And so I do research. So I take we take pieces of brain in kids that have bad seizures where I'm taking the brain out because that's what the seizure focus is. And we put it into a little kind of petri dish with a microelectrode array, and we record local field potentials, and then we look at compounds to see if it quenches the seizure. So it's like having a little piece of brain that's having a seizure in the dish, and then you put on compounds like seizure medication to see if it quenches the seizure, which is kind of cool. So I do, but I have a lab, and I very rarely get into the lab physically because I'm taking care of patients. But I mean, if you're going to be a busy surgeon or a busy, clinician, and you want to do research, a lot of times you have to surround yourself with people who are good researchers. And I've been blessed to work with a lot of really good people. So it's fun. Yeah.
Great. I was wondering if you know of anyone who does like clinical research in pediatric neurosurgery.
Well, yeah, I mean, a lot of people in our group